The whole aim is to empower females, so for them to be breast aware, is basically letting them understand, or giving them the knowledge of what their body feels like, and they are usually the first person to identify an abnormality. So a screened patient, when we use the terminology screened, a screened is an asymptomatic patient. She's just going because the recommendation is from the age of 40 every year or every 2 years to have a mammogram, and that's the reason why they're going. But as soon as you have an abnormality, whether it's feeling a lump, whether it's pain in the breast, whether it's a pathological nipple discharge, which is either a spontaneous watery or blood-stained nipple discharge, whether there's inversion of the nipple, skin tethering, or axillary lymphadenopathy. Now, those are all sort of more sinister sort of abnormalities.
So those are warning signs?
Those are warning signs. So should they pick up the warning signs, they would usually pick it up themselves. And sometimes subtle changes may only be picked up by a breast clinician.
And sometimes you could only present with one of those things that you mentioned. Right?
Yeah, or none of them.
Because sometimes a lump is just too small for you to physically feel when you are doing a self-examination.
Absolutely. And you remember, this is a physical structure that one is trying to identify. And if you've got dense breast tissue, and if you've got multiple cysts or nodularity, everything feels lumpy. So it may make it very difficult for even a clinician to identify these lesions. Therefore, we are dependent on the mammogram, which is a relatively cost-effective population-based screening tool that we can use for the identification of early breast cancer.
Also, whilst many people will look at the actual physical breast area, the breast area does tend to move towards the side and then up into the armpit, right? So that's also a common area that needs to be examined.
Yes, the breast extends up into the axilla. So although we used to divide the breast into sort of 4 quadrants, but there's a central quadrant and the axillary tail region. So these are all breast tissue, and some females would have a bit of hyperaxillary tissue, which becomes prominent during pregnancy as the breast enlarges. So that's also an area that one would need to feel.
So does fibrocystic breast, could it lead to cancer?
No, fibrocystic breast disease is not. It's not increased risk for cancer. The only problem is that it's associated with much more density in the breast, and clinically it feels like a lot more nodularity. So it may mimic cancer-like lesions, which sometimes you may miss it on a screening imaging in patients with much more denser tissue, or patients who feel the lump. They feel that, oh no, this is just one of those fibrocystic or asymmetrically dense tissue, therefore it's nothing. So they sort of just put it down to that.
So what causes the lump to form? Because whether it's malignant or benign, what's the reason for the mass to start growing in the breast?
So it always starts off with an abnormal cell, whether it's in the ductal cells or the lobular cells. So ductal cancer is the most common cancer affecting females.
So that's ductal carcinoma.
So that means it starts from the actual duct cells.
Right. So milk-producing mammary glands.
Yeah, so the milk producing is the lobular component. The ducts are the transport. So the transport from the lobules, which would produce the milk, and then transported via the ducts to the nipple areolar complex where the infant should actually feed. So the most abnormalities would occur within the actual ductal epithelium. Now, remember, for cancers to develop, there's a few things that need to go on. Each cell in the body has a sort of a suicide sort of instruction, which is what we call apoptosis. So if there's an abnormality, the cell usually kills itself off. But then if it doesn't, normally the immune system should identify this lesion and then kill it off. But if the immune system is impaired, then it can't identify these cells, and then it allows it to grow. But usually from a breast cancer perspective, it starts off what we call a hyperplasia sequence, which goes to mild, moderate, and severe hyperplasia. And then the next sequence of events is an in situ sequence. Now, in situ cancer is when the cancer remains within the membrane, the outer membrane of the natural ductal tissue. So in there, it goes to low, intermediate, and high grade. And then there's invasion of the capsule. So only once it invades the capsule is the term invasive cancer. But that is a term that only the pathologist would be able to confirm with us.
Right. So you mentioned just now low, intermediate, and high grade.
Yes.
So what can you just basically define, the three different types of low, intermediate, and high grade?
Well, this is under the microscope. What does the pathologist, what does a cytopathologist?
So this is at the biopsy phase.
This is at the biopsy phase, yes, but remember, the biopsy is representative of what is given to them in the sample, so it may not be representative of the entire lesion. That's why we got to remove the entire specimen so that the pathologist may be able to identify all the degrees of disease
Sure.
within that tissue.
So